All right. Well, good morning, good afternoon. It's a pleasure. I'm Jarad, a radiation oncologist in Newcastle and the deputy chair of the ANZUP prostate subcommittee, recently appointed. And it's a great privilege to have the opportunity to introduce and have a conversation with Felix Feng, amongst many other things. He's a translational radiation oncologist in San Francisco, and one of our guest speakers today. So welcome, Felix.
Thank you for having me, Jarad.
Yeah, so can you maybe just, I know you wear a lot of hats beyond just a plain old radiation oncologist. Are you able to just maybe give a little bit more of a background of your other roles?
Sure. So I'm a radiation oncologist, as you mentioned, at the University of California at San Francisco, and I'm vice chair of the department here. I also am director of a research initiative focused on prostate cancer. That's a university-wide initiative focused on laboratory science in particular. And then outside of the university, I head up the Genital Urinary Cancer Committee for NRG Oncology. And in that context, I'm overseeing about 11 phase 2 or phase 3 trials currently.
Great, a busy man. And I guess the NRG-GU aspect is kind of a parallel to ANZUP. And I guess you've now had a bit of awareness of what we do within ANZUP, both translationally and clinically. And I just maybe if you could just go a little bit deeper into the parallels and opportunities there.
Sure. And so many of you might not know what NRG is. It was formerly the RTOG, or Radiation Therapy Oncology Group. And what happened a couple of years ago is that group merged with two other national clinical trials groups in the United States and became the NRG group. But within the Genital Urinary Cancer Committee, we are a committee of radiation oncologists primarily, but also urologists and medical oncologists and pathologists. And we run a number of studies in the context of prostate and bladder and kidney cancer. Our emphasis is more on localized disease than metastatic disease. And in terms of accruals and so forth, we accrue from over 1,000 sites.
Great, and obviously a very long track record in the predecessor of RTOG as well, and a rich history to tap into, and it's great to have your engagement with ANZUP. I guess just wearing your translational hat, I understand that's been a real drive within NRG to embed that really right from the get-go within your clinical trials. Can you maybe just talk a little bit about that sort of pathway and maybe provide an example?
Absolutely, and so I think my primary research as a laboratory investigator is focused on identifying biomarkers that might predict response to particular therapies or might identify who has more aggressive or less aggressive disease. And a number of studies that I and many others have led have demonstrated that these biomarkers can actually add to standard clinical and pathologic variables in terms of helping to personalize therapy. And so one example of this, one biomarker that we're working with is something called Decipher, which is a 22 gene expression signature that can be obtained from any prostate cancer sample. And it's run by a company with the same name, Decipher. And the reason why we chose that particular partnership is that within NRG Oncology, we've realized that if we're going to run phase 3 studies, we ourselves can't handle all the biomarker work in an academic lab. And so therein is the importance of a kind of a partner in the industry setting that can take care of quality assurance and things like that. And so a number of our NRG members have shown that, for example, in the context of high risk prostate cancer, some patients actually don't need the standard of radiation and long-term androgen deprivation therapy. They could go with a shorter duration of therapy. And conversely, some patients actually need further intensification of therapy beyond this. And so we've actually shown that this Decipher genomic classifier can actually help identify patients even within the high-risk spectrum that have really aggressive disease or potentially not as aggressive disease. And so we are now running a 2,400 patient phase 3 study that's going to activate in a few weeks from now. And the PIs of this are Paul Nguyen from Dana-Farber and Oliver Sartor from Tulane University. And the trial basically is going to take patients with high-risk prostate cancer by NCCN criteria and test them with a genomic classifier Decipher. And patients at high genomic risk for metastasis are going to be enrolled on a phase 3 treatment intensification study where they're randomized to the control arm, which is radiation and long-term androgen deprivation therapy, versus radiation and long-term androgen deprivation therapy plus abiraterone and apalutamide, 2 next-generation androgen-targeted therapies. Patients with low genomic risk for metastasis are going to be randomized to, again, the standard of care, radiation and long-term androgen deprivation therapy versus a de-escalated treatment arm of radiation and shorter-term androgen deprivation therapy, and the primary endpoint is metastasis-free survival. We also have an imaging correlate in that with PET imaging as well. And so overall, this kind of involves kind of a novel therapy, a novel genomic biomarker, a robust endpoint, metastasis-free survival, and some cool correlative studies as well.
Yeah, and it's obviously exciting to be moving all that promising, I guess, retrospective evidence for some of these biomarkers into prospective validation, because I guess that's always been the missing link, hasn't it? And I guess your views of ANZUP as well. You've probably noted that we're really looking at translational sub-studies across the ENZUMET and other studies as well. I guess, do you see opportunities for greater collaboration between the collaborative groups?
Absolutely. I view ANZUP and NRG as kind of contemporaries, just in different countries, and one could argue that ANZUP is located in the far cooler country. By the way, I'm fond of Australia. And I think both groups have tremendous strengths in terms of the ability to accrue onto large studies, in terms of multidisciplinary teams, with surgeons and radiation oncologists and medical oncologists as well. But they also have unique strengths. So in the United States, it's easier for us to get biomarkers run. So, the Decipher biomarker is reimbursed by insurance companies, and we can get the tests back in real time after, 10 days after the sample is sent. And so that allows us some unique advantages just because of the biomarker infrastructure in our country. However, if you take a look, ANZUP is far better positioned to look at novel imaging approaches, in the sense that PET imaging, whether it's PSMA PET or other imaging approaches, is far more established in Australia compared to the States, and that's like night and day. ANZUP is way further ahead. And so I think to some degree that there are these individual strengths of each group. But, for example, if we design complementary studies that, have similar endpoints, have similar correlative studies, we actually might be able to compare across studies. And that's kind of one of the reasons why, I love being part of ANZUP as well.
Yeah, I guess there's lots of opportunities to design protocols right from the get-go, right through to sort of almost planned meta-analyses down the track. So yeah, there's lots of opportunity there. I guess NRG probably really started off as a pretty pure radiation oncology group, but with Oliver Sator and all these other agents now moving in, it sort of sounds like you really are trying to embrace multi-modality engagement. I imagine that's been a bit of a cultural shift within the organisation. I wonder if you just kind of, because that's obviously a direction ANZUP's obviously very keen to be in as well.
Yeah, so I think you bring up a great point. So if you look at the history of RTOG, which is now NRG trials, the history has been largely trying to establish what is the standard of care by which radiation should be given for patients with localized prostate cancer. And so in the past, we've done a lot of studies looking at radiation dose, the volume of the radiation field, whether hormone therapy should be given, the duration of hormone therapy, things like that. And really that's a credit to my predecessors in this position, Howard Sandler and Bill Shipley. But when I took over as the GU committee chair, it's been almost 2.5 years ago, we kind of sat down as a committee and we brainstormed about what would our next decade, where would that bring us? And to some degree, one of the emphases was going to be on biomarkers for personalization of therapy. But as you point out, one of the emphases was going to be on combining novel systemic therapies with radiation. And so we have studies with, abiraterone and apalutamide. We're working on, one with relugolix from Myovant. We have a large phase 3 with darolutamide. We have one with a PARP inhibitor, niraparib as well. You know, and we're also kind of branching out a little bit beyond just localized prostate cancer. We now will be having a study in oligometastatic prostate cancer. We're kind of partnering with another cooperative group alliance to do a study of abiraterone plus minus PSMA lutetium in the context of metastatic castrate-sensitive prostate cancer. And then, you know, we're going into areas where we've never been in terms of kidney cancer. So we're starting to look at the role of local therapy with radiation, potentially in the context of patients with metastatic renal cell carcinoma who are being treated with immunotherapy. That's a concept we're actively developing. It's not anywhere near activation yet, led by our renal cancer committee co-lead Raina McKay. And then we're also we have 2 studies looking at chemoradiation plus minus immunotherapy in the context of either muscle invasive or node positive bladder cancer as well. And really that's in kind of collaboration with other cooperative groups, the ECOG group and the SWOG group. And that's really led by our bladder committee co-chair, Jason Estacio. And so we're trying to become more diverse as a group. We're trying to adapt to where we think the field is going. And I think it's very similar to ANZUP in the sense that when you run studies in the context of a disease that has outcomes that require years to achieve, you kind of have to really take a guess as to what the future of the field is, right? In the sense that whatever trial we're running, it's not going to read out in 2 years or 3 years. You know, I sometimes joke around that I think they selected me for this position just because I'm probably going to be around, you know, in 10 years from now. I hope. I'm keeping my fingers crossed, you know. And you know, I think that in that regard, NRG and ANZUP are both very forward-facing groups, you know, bringing together kind of multiple disciplines of oncology to trying to kind of guess what that future of medicine will look like.
Great stuff. And I guess what we're really grateful for your engagement with our prostate subcommittee, and really looking forward to hopefully getting one of these projects that we can share and really get our teeth into, because as you might imagine, that's how the intergroup collaboration can really get started. Is you really got to kind of choose a vehicle and start pushing your pedal to the metal. It's a real shame we couldn't get you over in person this year, but I'm sure there will be other opportunities. Donald Trump says we're going to all be vaccinated by the end of the week. So we're looking forward to that. And look, it's been a real pleasure chatting with you, Felix, and I really look forward to your ongoing engagement with ANZUP. Thanks a lot.
Yes, thanks for chatting with me. Really appreciate it.